Good afternoon, everyone. I hope everyone is doing well and staying healthy during this challenging time with COVID-19. We recognize the hard work that you've been doing through this crisis, and we thank you for everything that you're doing to keep your residents safe, happy, and healthy. Thank you for joining PHCA for today's webinar, Unintended Consequences, COVID-19 Behavioral Health Issues. This webinar is geared toward nursing facilities, assisted living, and personal care. If there's anybody in your facility that you think would benefit from this, take your time and run out and grab them and have them listen in as we are, just going through the housekeeping items, and we'll get to our speakers here in just a minute or two. I'm Wendy Johnston with the Pennsylvania Healthcare Association. Before we begin, I have a few housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and to gain a better understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for PHCA members as well as potential members during the COVID crisis. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number. I'll be sending a link to a quick survey. Your feedback is important to us and our speakers, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit your questions using the question pane on the right hand of your screen, and our presenters will address them at the end of the presentation. Today's webinar is being presented by Kathy Adkins and Leta Kant, both Directors of Quality with RehabCare. Today's presentation will focus on behavioral health issues that are increasing due to social isolation from the COVID-19 pandemic. It's important for caregivers to stay focused on residents to quickly identify changes in mood due to social isolation. Rehabilitation has a role in evaluating the physical issues as well as behavioral health issues that are on the rise due to social isolation. An individualized, person-centered plan is developed by rehabilitation, and education is provided to the staff for keeping residents engaged in meaningful activities to keep them functioning at their highest level and improving quality of care. I'll now turn the webinar over to Kathy and Leta.
Good afternoon, everyone. We're just going to get started. This is Kathy. I'm going to start, and then Leta will be chiming in. So our objectives today are we're going to help identify the causes and risk factors of the behavioral health issues due to social isolation from COVID-19, identify the role of rehabilitation to work with individuals that have behavioral health issues. We're going to do some education for facility staff on the routines, activities, and meaningful activities to improve quality of life. And then we added one more objective to show you how the behavioral health does affect your quality measures, just to kind of tie it up. So we've got this quote in here. It says, "There's now compelling evidence that health risk of social isolation is comparable to the risk of smoking, high blood pressure, and obesity, even after controlling for other variables known to affect health." We do know that social isolation is causing a lot of issues with everyone, regardless of what your age is, but we really feel like people that reside in facilities, it's affecting them in kind of its own unique way. We hardly ever do a training that we don't talk about OBRA. So we know that every resident has to receive and the facility has to provide the necessary care and services to attain and maintain the highest practical physical, mental, and psychosocial well-being in accordance with the comprehensive assessment and plan of care. Every training that we ever do with any of our rehab staff, we always start the training with this because we want them to make sure that every person is staying at the highest level that they have possible. We do have a couple of the state survey guidelines for SNFs in here, along with some F tags, because we know under 483.40 that behavioral health services, every resident has to receive and they must provide necessary behavioral health care. And again, the OBRA guidelines are in there. So we want to make sure that they're functioning where they need to be and that we're addressing all those psychosocial issues that go along with it. And then we know that social isolation causes trauma, and we know that this was implemented in November of last year, that all the facilities have to provide training in trauma-informed care, and that falls under the quality of life information 483.25. So we know that residents who are trauma survivors receive culturally competent trauma-informed care in accordance with the professional standards of practice and account for the residents' experience and preferences in order to eliminate or mitigate triggers that may cause re-traumatization of the resident. There's actually some research out there showing that this social isolation is triggering trauma right now. So you can pop up and put in social isolation on any Google or internet browser right now, and there are headlines everywhere. These are just a few of them. Social isolation can hike risk of death from all causes. It'll help stop the coronavirus. Loneliness and social isolation are linked to serious health conditions. The social isolation increases the risk for COVID-19 as well as other health problems. And then 10 eye-opening statistics on mental health impact on the coronavirus pandemic. I just heard about a new university close to where I live this morning that just got a grant to study social isolation. So we know there's a lot of issues going on with it. And I think you're going to see several months down the road all the issues that have come up because of social isolation. So we're going to start with a case study. So this is Brenda. So before COVID-19, Brenda's schedule was pretty routine. She liked to participate in all the games and crafts that they did in the common room with the activities department. Her family came by and visited her every day. She loved going to the cafeteria to eat because she sat at a table with her best friend, Mildred, who has been her best friend ever since she's been in the facility. She really likes doing her OT with John and PT with James, and she loves coming to the gym early. She knows what her schedule is for therapy. She comes because she likes to socialize with all the people in the therapy department. She loved going to activities, especially church, music, and pet therapy. And then all of a sudden on March the 25th, that schedule came to a screeching halt. So now here's what it looks like. So her schedule is very different right now. She has to eat alone in a room so she doesn't get to see her best friend Mildred. Therapy is minimal, has to be done in a room. Her favorite therapists are no longer in the facility due to the quarantine because they are quarantined right now. Her day is consisting of endless TV programs. Her roommate got moved out, so she's in the room by herself. Their favorite staff don't have time to have a conversation with her now, and the family only gets to wave at her through the window, so she spends most of her day now looking out the window waiting for her family to come. So this is what happened to her because of COVID-19. Huge schedule change. And we'll talk a little bit more about Brenda when we get into the rehab portion. So, because we're going to kind of introduce her through the training. Just a few statistics. And this is just what's going on out in the world and statistics we found that are going on in some skilled nursing facilities. There was 1,000% increase in the SAMHSA hotline since April due to emotional distress. 65% increase in clients for Talkspace. 70% increase in stress, 15% distress in people over 65, 48% in alcohol sales since the pandemic because now people are day drinking. For every 1% increase in unemployment, there was a 1% increase in suicide and a 3% increase in substance and opioid use. A third of Americans between 18 and 29 now have anxiety, depression, or both. So it's really hitting the younger population too. And in the elderly, 14 to 15 suicides a day, one every hour and a half, and they account for 18% of the suicides that are currently going on in the United States. So let's talk first about social isolation versus loneliness, because there's kind of a difference between them. So social isolation is that state of complete or near complete lack of control between an individual and society. And that's what's going on in skilled nursing facilities right now. Brenda has no control over what's going on with her schedule. Loneliness is a temporary and involuntary lack of contact with other humans in the world and a lack of sense that you're belonging. So it's how you feel when you're alone, and it's perceived isolation. So let's talk now about some of the risk factors and causes. Why is social isolation so difficult for a human? You know, we're incredibly social species. Everything that we do revolves around some social thing that's going on. Um, Yossi Ginsburg was an Israeli adventurer and author. He survived weeks in the Amazon. He created an imaginary friend to keep himself company. That always reminds me of that movie Tom Hanks was in, where he made his friend out of the ball that he found. And then I'm going to call him Dr. C because I can't pronounce his name. He's a neuroscientist from University of Chicago. He has studied social isolation before he passed away for over 20 years, and now his wife is carrying on with the same research. And he said that research shows the effect of social isolation is as real as thirst, hunger, or pain. He goes on to talk about our brain and what happens in the brain with social isolation. So your brain is like a Wi-Fi signal. We've all experienced that, where you're working on something and all of a sudden the internet drops down to 1 bar, so you lose that connection. He said that's exactly what's happening with the brain. So if you think about your brain like Wi-Fi, there's a disruption in the signal because our brains are very social in nature. So, and here's what he says happens with it: the genes start turning off. It causes a disruption in your sleep because you're always in this hyper mode where you're constantly on guard for what's happening. You start hallucinating. It affects your executive function. It can cause an increase in stress. It causes you to anthropomorphize objects. So that is where you start talking to inanimate objects, like Tom Hanks talked to Wilson, the ball. It also can cause depression, anxiety, PTSD, and psychosis. And it can also cause problems with motor cortex, because what happens is you have a thinning that goes on to the myelin sheaths. And if you guys remember back to anatomy, that's really what happens when somebody has MS, because those myelin sheaths starts thinning out. So your brain is not communicating and it starts disrupting neurotransmitters. So what we kind of have going on right now is situational depression. So you have this short-term stress-related type of depression, and it develops after you've experienced some kind of traumatic event or series of events. It's just a type of an adjustment disorder. This can actually happen when someone moves into a facility, but that's currently what's going on with the pandemic. So we have situational depression going on. So some of the risk factors that happen is you have physical and emotional. So some of the physical things that happen from social isolation is inflammation of joints. So Leta and I were having a discussion about this because I have this going on right now because I have rheumatoid arthritis. And right now, when they did my labs, my inflammatory markers for rheumatoid for the sedimentation rate are off the charts right now. And there's nothing else that could be causing it, so they feel like it's due to stress. You also get headaches and migraines, not really any reason why they're there. Fatigue, they have trouble breathing, could cause stomach and digestive issues. The blood pressure increases. The heart muscle starts overworking. You get heart palpitations and pounding. You get sweating, worsening of existing medical problems, muscle tension and pain. Then you get the emotional aspects where changes happen in the sleep cycle. You have depression, PTSD, anxiety. You could have suicidal thoughts going on, restlessness. You feel like that you have no self-worth, so that's kind of decreased. Despair, you have decreased confidence, and then suicide, loss in the meaning of life, and you're negative. Other symptoms that happen with social isolation, sometimes you get difficult and aggressive behavior. You're going to see this a lot of times in your patients that have dementia or Alzheimer's disease. It's going to escalate because they don't understand what's going on. There's disorganized thoughts and speech. Someone that already has cognitive issues, it's going to make them get worse. They're going to have more short-term memory loss, difficulty problem solving. They're not going to be able to plan anything. Could be that maybe they're going to be self-harm there. That could be because they're having suicidal ideations. Could have swallow issues, substance, nicotine abuse, and the big one is they have a loss of meaning of life. So there was an article that was written. You heard me talking earlier about trauma-informed care. There's an article that said that it triggers emotions from past trauma. So it's re-traumatizing people because of the social isolation. because every person kind of has their own unique history, their strengths and their vulnerability. And any training you've ever done on trauma, someone has to have resilience to be able to get past the trauma. And if somebody doesn't have that resilience right now, the social isolation is going to make it worse. So the past traumas are going to have a powerful effect on the reactions that are going on right now due to the pandemic. So you could be re-experiencing and reactivating that past trauma. So some of the reactions you may get, you may have intrusive memories, could be triggered by something happening on the TV. Because if somebody's socially isolated, maybe all they're doing right now is watching TV. They're going to have problems sleeping because they're constantly on guard. They're going to have some problems with their emotions. They might feel numb, could be avoiding, and they could have negative thoughts. So this pandemic does count as a trauma, and that trauma causes changes to the brain chemistry and the neurotransmitters, which can cause all of these things to happen. I've got a slide on the neurotransmitters in just a minute. So depression, anxiety, insomnia, sleep disturbances, appetite fluctuations. It could cause weight gains. It could cause weight loss. They could have a panic attack because they're having all this anxiety, and all these people are running around in these masks and they don't know who they are. They're not going to have any interest in their past activities and hobbies, or maybe they're not available to them right now. Suicidal thoughts, and they just feel overwhelmed. So neurotransmitters play a huge role in what's happening, because you've got the adrenaline, that's that fight or flight. It increases and gets produced in a stressful situation, and that's what causes that increased heart rate and blood flow, which leads to a physical boost in your heightened awareness. You got the GABA, which is the calming one. So it fires the nerves in the central nervous system, and you have high levels of it to improve their focus. But low levels will cause anxiety and can contribute to motor function and vision issues. Noradrenaline, that's for concentration. It affects the attention and responding actions in the brain, and it'll cause the blood vessels to contract and increase the blood flow. Acetylcholine is what's needed for learning. It's involved in the thought, learning, and memory, and it activates the muscle action, but it's also associated with attention and awakening. So if you've got an issue going on with the acetylcholine that's not happening, then you're going to have all issues in all those areas. Dopamine is the one for pleasure. It also is the one for addiction, movement, and motivation. People will repeat behaviors that have led to dopamine release. So if the dopamine is not being released, they don't have that feel good. That's where you'll see the depression kick in. The glutamate is responsible for memory. That's the most common neurotransmitter you have in your brain that's involved for learning and memory, and that regulates development and the creation of the nerve contacts. Serotonin also affects the mood. That contributes to your well-being and happiness, helps with that sleep cycle and digestive system regulation. So it affects exercise and light exposure. And then the endorphins, the euphoria, is released during exercise, excitement, and sex, producing well-being and euphoria and reducing pain. So what's happening because of social isolation is you're seeing issues with all these neurotransmitters. They're either high or they're low, causing all the issues that we've just been talking about. I'm going to turn it over now to Leta to talk about the role of rehab.
Okay, the role of rehab. Some of the things you see on the screen right now are things that program directors or therapists have said to us is what's happening with them right now. And one of the things I think we have to look about, they found themselves running around for 5 minutes looking to find a pencil to help someone write. So a letter. So that is talking about the disorganization that they're feeling within this pandemic and the social isolation of not having an organized therapy jam or organized procedure to develop their treatment. We've slowed down and look at everything. One of the things that a therapist said to me, it's so important that they take time and slow down and really look at what's going on with the facility so they can identify issues and look at what's happening with the patients. And that goes along with we have to stop and watch what is going on and identify any issues that are happening. And then they found themselves holding someone's hand for 5 minutes just to help with that social isolation, that distance that patient really needed was extra time. So I think this is some good tidbits of what you might see happening within certain facilities. And then we have to look at the traditional rehab with this population doesn't always work with the individuals, and we're going to talk about what kind of rehab does work if the traditional rehab doesn't work. And we look at people with mental health, that we have to just go back one slide, Kathy, please. Mental health conditions deserve just as much support and compassion as people with physical health conditions. So even though the traditional rehab may not work with some patients that we're used to seeing with the physical health conditions, we still have to remember that the mental health, the behavioral health issues need as much attention. And then this is an important slide because I think we get caught up in looking a lot of times at the diagnosis that a person has and deciding what kind of need or what kind of beneficiary need for skilled care we're going to provide. And while we need to be cognizant and aware of their medical condition, it cannot be the only factor in deciding if a skilled therapy service is needed. It cannot be determined based on the diagnosis or prognosis. And that has to be very clear. We need to be providing skilled services, not services based on diagnosis or prognosis. And how do we identify the residents who benefit from rehab? I mean, this is always something that I think is a little difficult to determine during quarantine or what we consider social isolation. Remember a couple of slides back, look, listen, and pay attention to what's in your surroundings. That's what we definitely have to do. And we have to educate CNAs and nurses and everyone that is allowed in our facilities to be on that high alert kind of status to make sure that we're looking at our individuals objectively. And one of the ways we used to do a lot of it, but it's harder to do now with walking around during meals. We used to walk around and look in dining rooms to make sure things are happening. But now we have to rely a lot on who's triggering on our CASPER report. What are the quality measures telling us? What things can we get from the CNAs, information? And that may be to actually having some checklists, some questionnaires, so we can give the CNAs clues as to what we're trying to look for. The MDS, looking at the calendar to make sure, have we put our eyes on these patients? Are we screening when we're in there looking at one roommate? Are we looking or treating one roommate? Are we looking and cognizant of what's going on with the other roommate? And then our nursing documentation, are we putting our eyes on what one shift said from one to the other about what they may have identified with the patient? And always word of mouth with the managers, the housekeeper, maintenance, people that we may not even think about right now can be our biggest asset during quarantine because they may be able to spot things that we haven't seen going on with our patients. So everyone who hasn't been on therapy for a while, I say we need to look at, are they experiencing some functional decline based on everything that we just already discovered that happens with social isolation? So patient identification, we have to really look at observing, listening, watching, and then looking at what's happening within that environment. And that environment can be within the facility as a whole or within the patient's room. Things have changed dramatically. And we always like to put this slide in, I think, to think about, guys, keys to success. When we're looking at it, we all want optimal patient outcomes. We all want to be able to really express how well our patients are doing with our care. But how do we get there? And we're going to talk really quickly. It involves a comprehensive evaluation and treatment, even with our patients that are going through behavioral health issues, social isolation. We cannot stress enough that they have to still have that comprehensive evaluation. And our comprehensive evaluation, I like to break it down into three main things. You have to look at what your focus is. You have to look at what that patient's lifestyle, what is their priority, what are their main goals. Then you have to look at your assessment. What were the clinical needs? Determine what's going on with that patient. What is that patient's personal goals? What can we do to benefit that patient at this time? And then our approach, how we're going to collaborate between therapists, between nurses, between CNAs, between the resident. And then overall, guys, our approach has to be for the health and happiness of that individual. So when we're looking at comprehensive evaluations, we like to stress very much the occupational therapy profile. If we have occupational therapists going in there doing a comprehensive evaluation, then we want them to do the occupational therapy profile. Why? Because just what I said in the prior slide, the interests, the goals, all of these things can be collaborated and gathered while they're doing the therapy profile. We get all that experience, what the patient's needs may be, and like I said, their personal goals. And then something that we've added to a lot of our training now is the personal interest inventory, which is really a conversation that you're having with that patient. Or if you can't have it with the patient, are you collecting that information from the family member to get to know that patient, the nicknames, their favorite job, who is their best friends, what is their hobbies. So when we look at behavioral health issues, I think it is so important when we're doing a comprehensive eval that we take a step even a little bit further than we might do with a patient that isn't experiencing behavioral health and really pull up their interests, their needs, their personal goals, because it has to really be tailored to them. And then we always like to include, because therapists and nurses and administrators want to know, what kind of standardized tests can I have going on in my facility to determine what level or what kind of anxiety or what's going on with my patients, and how do I determine who has behavioral health needs and issues. And here's some of the tests we talk about: the geriatric depression scale, the generalized anxiety disorder, the global deterioration scale, Allen cognitive level. Why do we put the global deterioration scale and the Allen cognitive level in there? Is that cognition is a very important aspect for anything that's going on with behavioral health, because we really need to know what is being impaired. Is it depression, or is it a cognition issue, or could it be a combination? You have to really look at that. And then the pain scale. People can really be having behaviors that normally wouldn't if their pain was under control. So we know that the pain is very important. And then the perceived stress scale. How is that patient really perceiving what's happening within their environment? Physical therapy, I like to bring this up. What kind of things can they work with? Even though we've said it's not necessarily always traditional kind of looking therapy, but even patients with behavioral health, a lot of times if they have depression, they have anxiety, they're having certain kind of behavioral health diagnosis, we're going to notice that they have poor posture control. They may start to have issues with balance, with loss of muscle strength. They still need a lot of the basics to be covered, because they're experiencing what the behavioral health is doing is also affecting their major physical components and their activities. So gait, a lot of times if you've ever looked at somebody's gait that's very depressed, you will definitely see decreased heel strike. You'll see a shortening of gait step, more of a shuffle kind of steppage. And then a lot of times you may even see a little more trunk swaying. So there's a lot of things we can learn, and why therapy, even physical therapy, needs to go back in and work. And then on this one is the truth, safety, awareness. That is on all of them. Safety awareness is huge with behavioral health patients, because guess what? They're not really looking at their safety. They're not looking at ways to move within their environment safety anymore. That's not on their radar. So that has to become on our radar of how we're going to make sure that they're safe. And then the literacy level. It is really important to know what level that patient is able to communicate with you, their reading ability, their cognitive ability, and their ability to let their needs be known. And then OT, we've talked a little bit. I think it's very important for all of us to learn about eye contact, because someone with behavioral health issues, a lot of time you're not going to get the eye contact. They're going to have sensory awareness disorder, in that they are either hypersensitive or have very little sensory awareness to their environment. We see a lot of the judgment, social skills. We've already talked about the history of trauma. Important too to know what their hearing is, how much we know that they're able to hear or not hear. Coping skills, sleep patterns, all of the same things that we've talked about. And then the medication assessment. Speech therapy and occupational therapy both have skills to really look at the medication and figure out, is this a cause and effect from taking that medication, or is there something we need to do to adjust the medication and get help with that. Speech therapy, there again, they're going to be helping with sequencing is so important. Sequencing just their daily activity, their schedules, sequencing basic tasks that need to be done. Their reading comprehension, and also both speech and OT are very good at looking at their leisure activities, interests, and skills, and how we're going to make that a productive kind of environment for them to be able to have leisure and activities. Attention and concentration is definitely a huge issue that we have seen with behavioral health patients. So goals for all disciplines that we have to really look at, no matter who's involved in this, is objective, functional, and measurable. We still have to provide skilled intervention. It still has to be related around function. So they may have a behavioral health issue. How is that impacting their functional capabilities? Are we making sure that we're addressing all their needs that impact function? And can we measure that? So we're going to focus on their functional deficits. We're going to focus on the individual's overall function, how it is affecting their quality of life, how it's affecting their personal skills, their relationships, and then how does it promote independence, or how are they handicapped in the sense that they're not able to be independent because of these behavioral health scenarios. And social isolation has definitely affected our independence. So now we're going to look at some rehab strategies. And when we look at depression, some things we have to think about when we're working with patients with depression during this time. We have to keep our goals low. We cannot be writing these big lofty goals. We have to look at things that we can show outcomes in a slower method. We need to work slower. We need to remember touch as encouragement. We want them to participate in activities. One of the worst things we can do with someone that's depressed is not give them praise and allow them to have some independence. It may be as simple as them tying their shoes or they're putting on their own shirt. Yes, it's quicker if staff does it for them, maybe, but that's going to cause them to be more isolated, more depressed, because they're going to think they cannot do anything for themselves. So we want to make sure that we're giving praise daily, and we want to encourage them with outside activities or with any of their leisure activities, things that we can get them more involved in. So that's the thing to look at depression. Now, suicide. We need to make sure that anybody that's talking about, I wish I would just go ahead and die, I wish I wasn't here anymore, no one really has any need for me to be here, any kind of negative statements like that, we need to take that seriously. And we need to tell our staff they need to report it immediately, because we want to keep the patient calm, but we also want to make sure that we're putting systems in place to reduce the chance of anything happening to that patient. And we want to look at the environment, make sure it's safe, make sure that we get the right medication, we get the right systems in place to support them. And then anxiety is something that we're seeing huge things happening, not just with our patients, but with our staff, with our family members. And so what we have to look at is focus on coping strategies. And what I've been telling therapists, focus on what you can do, not what you can't do at this point in time. Focus on stuff that can be meaningful to you and the patient, and make sure that you spend time with that every day. You want to try to eliminate the source of anxiety. We can't remove the pandemic right away, but there may be some things that we can work on to reduce that anxiety. And you want to definitely look at any trigger points that are causing anxiety. Maybe it may be loud noise. Maybe it may be that their trigger point is that they get very anxious every time meal comes because they know they're going to be eating alone, or they're not getting their wish of what they want to eat. So now their anxiety goes up around meals, and then they end up having weight loss because they're not eating. So we have to look at what the trigger point could be. And then the best thing I tell therapists, teach relaxation techniques, talk about your deep breathing, teach the patient how they can talk about with you and judge the pain, relax through things, maybe in the morning, certain exercise routines that they can do by themselves, and then some quiet time where they can reflect. And then everyone knows, without any further ado, that physical exercise helps release the endorphins in our body, helps relieve stress, and it maintains our mental health. And as you see, these are pictures of when we were able to do group activities. Patients were able to be on and look and get involved and be participatory in a group technique. Now they may not be, but what can we do in a smaller number? What can we do in the room with our patients to encourage them to have some physical activity? We need to create that kind of environment. And insomnia and sleep issues, we've touched on this. Some things they talk about: exercise at least 30 minutes before you're going to go to sleep, because you want to make sure that you have time for your body to get into a sleep routine. You want to go to bed and wake up at the same time. This is so important. And right now with the social isolation and the pandemic, a lot of times they don't even know what time of day it is, daylight, not daylight, and their routine needs to be back to as normal as possible. And then they need to get out in the sunlight. If they can go out into a courtyard, if we can move that to help with that sleep-wake cycle. That's something we might not be talking a lot about, but that's affecting our residents very much. And then we're back to case study Miss Brenda. So let's look at what we would have done for Miss Brenda right now. We're definitely going to look at referring her for a comprehensive eval. We are looking at her being sort of despondent, maybe depressed, looking out that window. We know what has happened in her day. So why was she referred? Because we have concern of her decreased activity, her cognition, maybe her depression, maybe she's had some weight loss. There's a lot of things we need to look at. That may be a reason to refer. And then we have to look at which discipline, PT, OT, or speech, might be the most appropriate to work with her. And then what interventions would work best for her. Putting her on some kind of isometric exercises in her room, working on some relaxation techniques, maybe working on what is some of her food preference, and then also working on some things that we could do of her interest level, leisure activities that we could be able to do within the room. Then we might be able to set up phone calls, things that we could bring in more of her family contact through letter writing or phones or whatever we can do. They've said that in social isolation, text message doesn't work as good as actually a phone call or a video, Skyping or doing FaceTime with our patients. So I think we need to think about that as something that might help with Brenda.
All right, so staff education. Some of the important components of working with people with behavioral health issues, you have to have cross-disciplinary intervention, regardless of what the setting is. Everybody needs to be communicating and on the same page with everything that's going on with them. So it is key, if rehab's worked with somebody, they find activities they like to do, they need to educate the staff. Maybe they found out that their routine is that they want a certain type of food on certain days of the week. You know, I'm from the South, Leta's from the South. Catfish Friday is a big thing. Cocktails at night. You got to find those things out and try to do everything you can to accommodate it. So you may need to pass that education on to people. Care planning is key. It's all about that individual person and that person-centered care. And then if somebody's going to be leaving the facility, hopefully that's happening. I am seeing videos where they're posting where people are going home post-COVID. Then you got to start discharge planning to plan back to the environment that they're going to. If they're going to stay at the facility, maybe rehab has found out the activities they like, certain days of the week, certain things they like to do, pass that on to the activities department, or transfer them over to restorative nursing. Or if they live in assisted living, find out maybe you can refer them over to a wellness program because you feel that it's key that they continue to do exercise and that's something they're interested in. So those are all important components that everybody needs to be talking, communicating, and planning in the same way. And it's all about those meaningful activities. What do they want to do? We have our own agendas that we want them to do, but what do they want to do? We do that personal interest inventory and that OT profile to find out what their leisure activities are. There are some calming activities because you can use sensory, maybe music. Music is very, very good for people. And even patients that have cognitive deficits can listen to the kind of music that they like, and you will hear them singing even if they can't communicate with you. Maybe there's certain movies they want to watch. Maybe there's books. You know, a lot of people don't read books now. They do it on a Kindle. I personally still like to read a book, so I buy books and read them. Rocking chairs are wonderful. I know they're dangerous when it comes to falls, but if you have the kind that lock when you get up, then those rocking chairs are wonderful because that gives that deep vestibular movement that you need that is calming. And you know, when you had babies, you rocked your babies. It's the same way. You rock yourself. That has a calming effect. That's a neurologic thing. And that can last 2 to 4 hours. So maybe somebody sitting in something as simple as a rocking chair is a good thing. We use rocking in therapy all the time when we're trying to work with people on their vestibular, but we also use it from a sensory perspective for sensory awareness to try to get them to a normal arousal level. Because if somebody's having that panic and anxiety, you can use that rocking chair to bring that arousal level back down to a normal arousal level rather than being in a real low one or a high one. Because it's the same way if somebody's really low, they don't have any energy, they're depressed, they're moving really slow. You can also use that rocking chair to bring them back to that normal arousal level. And that's when you're going to get your maximum effect of your functional activities that you're doing. Maybe you can do one-on-one time sharing stories. People love to talk, and I personally love talking to people because you learn so much from their stories. You know, we always said in my family, we wished we had written down all of my grandmother's stories because when she got dementia, she would sit and tell the same story over and over again. But nobody remembers those stories now because when she passed away, the stories went with her. And their stories are very interesting. Group activities, when you get to where you can do them, and maybe if you can't do it in a large group, you can do a couple of people and do a group activity. I've seen people doing bingo in the hallways where they spread them out. I've also seen them doing cornhole where they're tossing. That's a big thing you see in the South around family reunions and stuff. Bowling. We do cocktail hour in the South. You know, a lot of times there's a facility where Leta lives that is a dementia facility, and they have cocktail hour on their porch at night because the way the facility is set up, they have a porch and they do their mocktails, but it's the cocktail hour, and that's what people are used to, so they do their cocktail hour. So there's all kinds of ways. You just have to find out what they like to do. And you have to empower that resident. What's important to them? So help them figure out what's important and meaningful. And if they can't tell you, it's worth picking up the phone if the family's not there and learning that information to them. We always train our therapists when you're doing your evaluation. If the patient can't give you the information you need, call the family and go through that personal interest inventory or go through the OT profile so you can learn as much as you can about them. We need to focus on prevention and not reacting to the crisis. Right now, we all seem to be in crisis mode, and we're all trying to figure out, because we all got thrown into a loop. Like, you know, our case study we presented today, Brenda, all of a sudden her schedule just came to a screeching halt, and her whole world changed on a dime. And I know that's happened to everybody that's on this call because that's been globally across the United States. So everybody has had to learn how to deal with it. Give them time to speak. A lot of times, if they have a cognitive issue, they have dementia or Alzheimer's disease, and then they have another behavioral health issue on top of it, it'll take them a second to process the question and be able to respond to you. Allow them to have time to do things for themselves. You heard Leta talking about this. It's very important that if they can still feed themselves, brush their teeth, comb their hair, put their shirt on, that you allow them to do that. When we do it for them, we do it a lot of times because there's not enough staff around, and we do that learned helplessness. So they will just hand you the shirt because they know it's faster, you're going to do it, so you can move on to the next person. And then offer them choices, but keep the choices limited. maybe to 2. You want the red shirt, the blue shirt, and keep it that way. You don't want to give them a whole bunch because they're probably not going to remember what you're saying if they already have cognitive issues. So you are powerful. That is a very powerful statement right there. So you want to live in you want to have a meaningful purpose. Give them their choice, their meaningful activities, time to speak, time to do activities. Even if you can't do group activities in the building, maybe they like to do word searches. One of the managers the other day called me and said, I had a patient that was so depressed, and she said, I started talking to them and they said they love doing word searches. So I went to the dollar store and I spent $1 and bought them a book. And she said they just lit up. And now every time I go in the room, that's what they're doing. So that was important. And that was a meaningful activity to them because that was a normal activity. Give them the opportunity to participate, allow them the ability to be independent, and then connect them with activities that they want to do. We use this for training. And if any of you guys get our Partnership First emails, this actually came out today. We've got strategies in there for dealing with individuals that have behavioral health issues. Communication is very important, and you want to make sure you're communicating in a way that they understand. And then you got to watch your body language, because if you put your hands in your pocket or cross your arms across your chest, that's a defensive posture, and that may escalate or trigger some kind of behavior. So we have give information about this. So how does this help you? Leta, I'm going to turn it back over to you.
Well, as administrators and DONs and therapists on the call, how does this help you? Looking at what we've talked about so far with behavioral health and social isolation, what are we trying to do? We're trying to optimize our patient outcomes. We want to improve our interaction. So now you have some tools to go back and ask questions to try to see how we're taking care of our patients. Also, it helps us optimize for discharge home and placement back into the community, because now we are looking at tools, using different tools to help that patient be healthy. Educating the therapists around behavioral health, that's one thing that I think is so important. A lot of therapists, I'm a physical therapist, we didn't get a lot of training in behavioral health. So a lot of it was just learn behavior as I went through treating patients. But no, we have resources, things that we can do and things we need to look at to help our patients through the behavioral health crisis. And then look at our therapists, how they can interact. What we want to be able to do is teach them how to interact and treat patients with these diagnoses. And the last thing how this helps us is we want to be able to communicate with our CNAs, with our nurses, with our therapists and our family, and do education around the behavioral health and social isolation aspects. And some of the things that I think as administrators and DONs, we look at the benefits of knowing what behavioral health is, how we're going to treat it, and what are the signs and symptoms and things around it, because it benefits us with our quality measures. And I just pulled out some of the quality measures that we have to address. And that's the depressive symptoms is one, who received antipsychotic medication, who's used to having anti-anxiety or hypnotic medication, the prevalence of behavioral symptoms, and discharge to community. See, all of this ties up to what's going on with our behavioral health patients. And then also with here on your CASPER report and things that you get routinely, just look down. If someone's having a behavioral health issue, how it affects all these different measures that we are addressing on our MDS routinely. And so I think that's just, it ties in beautifully. And then on our MDS, I started to try to just pull out which MDS would respond, which section on an MDS would respond to what you're dealing with behaviors. Well, hello guys, look at it. Almost every section on the MDS can correlate to a behavioral health issue. So we need to make sure that we are addressing our behavioral health issues with our patients right up front. And then the last thing we put in here, one of the last things is to just tie it back together to exercise and everyday activities. It all goes together to have a good behavioral health plan for our patients and identify. With exercise, it helps with their endurance, their strength, the flexibility and balance. So all of that ties directly right into our well-being.
And the
And the
last thing we have.
Okay.
Go
ahead.
ahead later.
Oh, you go ahead.
So we have, you've seen on our training PowerPoint that we have Hope Conquers. We actually have created and designed a whole behavioral health program. And what you guys got today is just a touch of it. So if you work with our company or you have contracts in our building, this is a program that we are training right now, therapists. And our whole goal about it is person-centered care. So we can get them back to their individual functioning at the highest mental, physical, and psychosocial level, which is the OBRA guidelines. And we are training our therapists on a lot of the diagnoses we've talked today. We have 5 diagnoses that we get into depth, teach them about the diagnoses. We go through the medications that go along with those diagnoses. We go through the neuroanatomy, give them a quick neuroanatomy review, like I gave that one slide on the neurotransmitters, because a lot of what's happening with behavioral health has to do with neurotransmitters. And then we teach them how to do a comprehensive evaluation and then what type of treatment they need to do. We gave you guys just kind of a touch of what we do with an evaluation and with some of the treatment strategies today. And then we thought we just kind of ended up with some resources because everybody is dealing with their own issues that are going on. There is a suicide prevention line, the 1-800-273-TALK. There are national helplines that are out there. So you heard me talking about the increase of the calls that were going to SAMHSA. So there are always people out there that are willing to talk to you. And if you just need help on your own, you can direct people to these numbers. So we just kind of put them in as resources. And then if you want more information about our company in general, here's Randy's information. So, all right, Wendy, I'll turn it back over to you for questions.
Great. Thank you, ladies. That was really good information. I have a rocking chair at home, and I think I'm going to have a cocktail and rock tonight. That sounds like a good plan to me. At this time, we're going to open up for questions. If you have any questions, please type them in the box on the right hand of your screen. And we'll just give it, a couple minutes here. Just be reminded that PHCA is offering many COVID-related webinars these days. We don't have anything scheduled right now, but just continue to watch for the daily communications and also the our website. There are webinars coming up. We have a leadership series coming up starting in July, a 5-part series. Check that out. I know that's on the website, and we are planning other webinars. If there are any topics that you would like us to present, please, feel free to be in touch with us. We will seek out, those speakers for those topics. This was great today, ladies. This was really good and very timely. I know, at the beginning of the whole crisis, there was a point where I was feeling like, I was ready to climb the walls at home, and then felt, anxious another week. So yeah, this is hitting everybody on some level, I think. All right, this is a quiet group today. There aren't any questions. Again, if you have any questions, we'll be sending out the PowerPoint slides as well as the link to the recording and the survey. So please take time to complete that. And again, look out for more of our PHCA webinar offerings coming soon. Just want to thank Leta and Kathy again for presenting on this topic. It was great information. And just want to wish everybody a great remainder to your day. Stay well and healthy, and thank you for all that you're doing in your facilities. It's not going unnoticed. You all are rock stars. Thank you very much.